evening. It's our last event of the year. We haven't got anything planned for the new year yet, but Mel and I will have a look at getting some dates planned in. So if there's anything that you would like to see in particular, then if you want to put some notes on the feedback, and we'll go through that at the end. Sort of the end of the year, and when we're planning all of our next sessions, and we'll try and get something booked in that's relevant to your learning. So we've got Mr Abdelaal with us this evening to talk about enhanced recovery after surgery and what to expect after spinal surgery, including post-operative complications. Can you just move the slides on for me, please, Mr Abdelaal? Okay, so yeah, same rules as per usual. So if you can make sure that your device is muted throughout the session. If you've got any questions, if you want to type them into the comments box, I can ask them on your behalf, or you're welcome to ask Mr Abdelaal. There will be a couple of breaks for questions, sort of one midway and then one at the end. So if you have any questions, it's possibly best to wait until it's a convenient time or throughout the presentation. We'll obviously do our best to answer any questions that you have, but time permitting, feel free to turn your cameras on if you want to, although you're certainly not obliged to. We're going to record this session. Recording will be sent out, a link will be sent out with CPD certificates in the next few days. We'll also share the slides as well, so they'll also go out with the CPD certificates. Can I have the next slide, please? And if you're logged in under anyone else's name, please can you let me know who you are? If you just want to send me an email with your name so that I can send out CPD certificates, then that would be great. So if I can just introduce you now to tonight's speaker, sorry, it's Mr Ahmed Abdelaal. Thank you very much, Mr Abdelaal.
Thank you very much, Vicky, for the introduction. Thank you everyone for joining. It's really nice to be here. Vicky, you can hear me, can't you?
Yeah, I can hear you.
Okay, perfect. So my name is Ahmed Abdelaal. I'm one of the spine surgeons at the Nuffield Hospital. My NHS practice base is the University Hospital of Coventry and Warwickshire in between Coventry and Rugby. And of course, I do some private work in at the Nuffield in Leamington Spa. A little bit about me. I'm orthopedic surgeon by training, so I've trained in all aspects of trauma and orthopedics before specializing in spine surgery. My orthopedic training was in Wales, and the spine training, the specialized spine training was between Alderhay Hospital for pediatric spine, followed by Stoke-on-Trent, and finally Oxford for fellowships before joining Coventry Hospital and then Nuffield this year. So we chose the topic of enhanced recovery program after surgery because it's something that I get asked about quite frequently, especially from physiotherapy, but it's also because it's part of the multidisciplinary approach to work in all aspects of surgery, really, particularly orthopedics, and now it's including the spine as well. And that's all to talk about the journey of the patients from when we meet them up until they are back in the community again after the surgery. So you might be aware of some of these acronyms about fast track surgery or accelerated recovery or rapid recovery, and of course finally the enhanced recovery after surgery, or ERAS. So of course, as you can see from these names, especially the first three, they are all about the speed, which is not always the case. So it's not about having a speed recovery or doing things fast or sending the patient home very quick unnecessarily. And that's probably why I don't like the first three, and it matches perfectly well with the enhanced recovery, because that means it's a good recovery in all aspects, including patient experience and outcomes. And we'll talk about that in more details. So the whole idea of this enhanced recovery, or ERAS, started in 1997 by Henrik Kellett from Denmark. He was actually a general surgeon, and he dedicated his time to developing this approach. And from his first paper about the multimodal, meaning multidisciplinary approach to controlling all aspects of patients' recovery, the results were quite outstanding straight away, and that was taken quite fast by all aspects of surgery. The first one was the colorectal surgery, and that made a transformation in patients' outcomes. And not far away, then it was taken by all aspects of surgery, including, of course, the orthopedics, and that is now part of the very well established recovery program after hip and knee surgery. And now, of course, it has been spine has been included in that, but not just orthopedics. In all aspects of surgery, including neurosurgery, cardiothoracic surgery, general surgery, including colorectal and hepatobiliary surgery, pediatric surgery, all aspects really. And that was from Kellett's original words. Is the hypothesis that by the combination of multimodal, meaning multifaceted types of care, and that has to be evidence-based care. So it's not just haphazard things. Everything will be monitored, and outcomes will be looked at and evaluated and analyzed, and protocols will be changed accordingly. And that was the main aim, is to enhance the recovery. And I just need to emphasize on the word enhance the recovery. It's not just making it faster. It by enhancing it, improving the patient experience. And that will subsequently, as a byproduct, will decrease the need for hospitalization. So the hospital stay will eventually become less, improve the convalescence and recovery after surgery, and hopefully decrease the level of risks and complications and morbidity that can happen after surgery. So to start with this, then the old dogmas has to disappear really, and there is a lot of misconceptions about recovery after surgery, and what we need to do before surgery to improve that. And these are some of them. So bed rest protects. No, it doesn't. It doesn't actually protect from much at all. Bed rest can increase risk of complications, including blood clots, pressure sores, chest infections, water infections, and it just makes life miserable sometimes. Brace and collar is the rule. They have a place definitely in all aspects of orthopedics, and spine is not an exception. But this is not the rule. We use them in really exceptional circumstances, and I've tried myself things with a collar and without a collar, and I didn't find any significant difference. So now I don't use it routinely, except in cases for trauma and stuff like that, but not routinely for the elective cases. Morphine is not the best painkiller. No, it has a lot of side effects, and it can affect patients afterwards with all sorts of risks and side effects that they can experience, and that can definitely delay the recovery, delay them getting out of bed, expose them to all the constipation and all aspects of side effects from the morphine. Another thing is put a drain just in case. Again, I don't routinely put a drain anymore because I didn't think it make much difference, except if there is something in the operation, and we'll touch about a couple of these indications later on. Mobilization is for small surgery. No, it's mobilization is more important for the bigger surgeries than the small surgeries. Small surgeries, people will recover usually with or without, but mobilization enhances recovery after bigger surgery. Rest in bed today, and we start physio tomorrow. Again, I'm very strong proponent for starting physiotherapy straight away. I take urinary catheters, for example, straight away, so patients can get out of bed and move to the toilet if they need to. Of course, there is exceptions to every rule, but that's not the routine. To keep a drain in, that's the exception. And probably one of the biggest ones is that last one. We've always done it like that. And I think we've all, in all our practice and life in general, we've stuck to things because we've just done it for so long. But if we think about it, if we monitor our practice, and if we look at outcomes and listen to patients and what they say, we'll realize that it's not really that difficult to change what we've done for a long time, if it is for the best. So 7 pillars of ERAS. So it's the number one is patient education, and that starts from when we see them in the clinic. The more information you give patients, the more they are well prepared for their procedure, and that reduces their anxiety about it as well. And part of this patient information is by directing them to the information leaflets that hospitals provide. And for all spine surgery, there is of course the BAS website, which is the British Association of Spine Surgeons, which has a dedicated section in it for information for the patients about various conditions and procedures. And all patients find that helpful without an exception. Second thing is protocol management, is by creating that culture of having protocols in place and talking to people and colleagues, from nurses to pre-assessment staff to physiotherapy, and that's mainly to create this environment of where we listen to patients and see what best for them, and change our practice accordingly. That's of course it's all done through a multidisciplinary team approach, including everyone that is involved in patient care. Stress control and pain management, and again that starts from before the operation, goes through the operation, and continues to after the operation. That has to be in line with the anesthetist that we work with as well, because a big part of that is what they do in the anesthetics, and of course big part of it is what we do in surgery. But I have to say this is actually the small part. Stress control and pain management starts from the preoperative assessment and the patient education in clinic, and the majority of it happens after the operation, and particularly when patient is back in the community and seeing the physiotherapy and the nurses at the GP surgeries. Early feeding and mobilization. That is very important. Anyone that is recovering from surgery needs good feeding, and it is early. That makes them feel better and enhances their recovery, that's for sure, as well as mobilization, as we spoke about. It reduces significant amount of risks, especially blood clots and pressure sores and infections. Secured discharge, and by meaning secured, I mean that the patient knows what they are going out of the hospital into. So making sure that they have all the arrangements at home that they need to be, but also they know that they can come back to us. There is a link and an open channel between patients while they are at home and us, whether that is via phone calls or via open appointments, and in some places they even have apps that the patient can communicate with the hospital via these apps, and that gives them a big peace of mind and makes them more keen to go home as soon as possible, because they know that they have an access to the healthcare professionals if they need to. And of course, nothing will happen without evaluation of the data that we collect on outcomes and patient experiences and feedback. There's some more.
Mr. Abdelaal, sorry,
hello.
can I just quickly ask? We've just had a comment to say that someone can't see the slides. Just wanted to check, can everyone else see the slides? Yeah. Okay. All right then. Yeah. Sorry, if you want to continue.
Yeah. Okay.
Yeah. Thank you.
So a few more extra bits is the septilucent. So that's very important, and that's now, I think, established protocol with the anesthetist. There is no need to fast the patient from the day before, or they don't have anything to eat or drink. They become dehydrated and groggy. But no, they can drink up until we send for them. So that's pretty much 15-20 minutes before the start of the anesthetic, so even less. And that has been proven very safe. Get up as soon as possible. Again, I cannot emphasize enough about the importance of early mobilization. patients, we ask them to bring their own clothes, so to avoid what we call pajama paralysis, because if they wear the hospital gown and they stay in it, they feel like patients rather than individuals or people. So we need to make them feel like they are themselves, so they can get up and start getting on with things, and most importantly, physiotherapy. And again, the contact point after discharge, and we touched about that before. Oh, can you still see me? Vicky, can you still see the slides?
So no, I can't see the slides. Do you want me to share the slides, or do you want to try sharing them again?
I can try and share them again. How about now?
Yeah, that's it. I can see them.
Okay, perfect. So this is the pathway for enhanced recovery after surgery, or the ERAS, and any paper that is published about that topic, you will find some sort of this flow chart about the patient journey from pre-admission to the day before the operation, or on admission to the operation, and then afterwards. And if there is anything to highlight, it would be these probably the 3 bits that I highlighted, because we are not here to talk about what happens in the operation itself, but all the things that happen around it. So it's very important to have the pre-operative information given to the patients, and giving them these leaflets so they can have at home, so they can go back to it. And after the operation, of course, it's the same thing. It's to avoid morphine, early mobilization, and early feeding, and early discharge back to their community, with an open channel for them to go back to. So for that to happen, there has to be a paradigm shift, and so this became now one of the most famous slides for the ERAS syndrome. So this is a graph that is, as you can see, it's stating the tissue damage and insulin sensitivity, which is basically measuring the metabolic state of patients after surgery with the ERAS protocol and without, through the traditional. And you can see 2 curves there in relation to time. One of them is definitely longer than the other, and also the amplitude of the change is significantly bigger for the traditional care without the ERAS, which it gives you an idea about how the ERAS work. And the difference in time, so that is reflecting the importance of the patient experience, because with the enhanced patient experience, and that is highlighted because of the difference in the amplitude of both graphs, you see that the one graph is shorter. So reduced length of stay is a byproduct, is the result of having the ERAS protocol done properly. And now there is ERAS Society, and that's the emblem of it, or the logo of it, and you can see under the ERAS Society pictures is the 2 curves, and that is basically taken from this graph. So why ERAS is something important, and there is rationale for it to be in spine surgery. Of course, it's all to do with the trends and volumes, so that the volumes of spine surgery has increased significantly. So if we look at the past decade, this was looked at about 5 or 6 years ago for the previous 10 years, and there was about 13% increase over the previous 10 years in amount of hip and knee surgery that happens. While if you look at spine surgery, there was an increase of over 130%. So the trends and the volumes speak for themselves in spine. Risk and complications. So risks do happen, and complications do happen in spine surgery. And now there is a strong evidence that by changing the patient journey, by things pre-operatively and post-operatively, we can reduce the risk of and complication of spine surgery. And that has been proven in lots of other surgeries as well. In one of the studies, colorectal surgery complications and risks was halved by the ERAS protocol, and similar in orthopedics and hip and knee surgeries. Risk of complications were reduced by about 30% in some studies following the use of enhanced recovery programs. And I don't think there is any implant or any form of a hip replacement or knee replacement or anything that we can do as surgeons that would improve patients' experience and reduce the risk of complications by that much. Variability of length of stay, of course, that is, as we said, that is a byproduct of having a good recovery in theatre, and with that, it's not just the outcomes and patient experience, but it also it saves money and it saves hospital stay. Everything is done because of the pain levels and patient experience, and if they are happy, that's why we work in hospitals to improve patient experiences. And we've also noticed that metabolic demands and surgical stress response that is significantly reduced following ERAS. And as we said, that journey and these responses start from the day that the patients are seen in the clinic, and once the decision has been made for surgery, then it follows through from the pre-operative assessment, from admission, surgery itself, recovery, and the physiotherapy afterwards, all the way to the discharge and review in the clinic afterwards. So this is the pathway that we usually tend to do. So once the patient has been decided that he or she is having an operation, the education for the patient starts pretty much straight away there and then in the clinic, with the information that they are given in an easy language and information leaflets for them as well to take home. And then on the day of the operation, they are usually given the fasting guidelines and requirements for them. They are usually admitted on the day of surgery, and they have all the showers with the disinfectants to reduce the risk of infections. I very much like the idea of them walking themselves into the anesthetic room if they can. It makes them feel powerful, and it makes them more confident that they are going very soon to be walking out afterwards as well. In the operation itself, so it's all about minimally invasive technique, soft tissue handling carefully, minimize bleeding and controlling bleeding. These are the things that we can control in surgery. And from the anesthetic point of view, of course, with the analgesia, so we don't wait until the patient has a pain response, even if they are anesthetized. We start giving local anesthetics and painkillers before we start the operation. So hopefully stop that pain pathway from being triggered in the first place. Avoid morphine afterwards for all the possible side effects that we said. Early mobilization with physiotherapy, and discharge from the hospital as soon as possible. And once they are at home, we keep in contact with them. I usually see them in about 2 weeks in the clinic, or they are seen by someone in the clinic for wound check and to make sure that everything is going well. And then we see them again at about 6 weeks. And then from there, it depends on the nature of the operation. Of course, if it is something that we need to monitor for a long time, we do that routinely. But if it is something that's simple and we leave it with an open appointment for well over a year, like an open door policy, if they have any problem, they can easily come back to us. And of course, yeah, I forgot to mention, of course, we collect outcomes for patients, and these are sent routinely through something called the BSR, or British Spine Registry. So everyone who's having a spine operation, their details go into a registry, which is part of the government NHS type approaches to collect these data. And it's not personal data, it's all about the outcomes. So they will, once we register patients by the emails, they get a questionnaire about their symptoms and their condition before the operation. And from that, they calculate a score about their pain and how they are coping. And then the same questionnaire are given to them after the operation at 6 weeks, 3 months, and a year. And that's mainly to make sure that people are improving after whatever we do. So these are the common spine surgeries that we do, well, at least at the Nuffield So lumbar procedures, including lumbar decompressions and discectomies. We do lumbar fusion surgery, which is either posterolateral fusion only, which means like putting pedicle screws and rods in the back of the spine, and that's to stabilize it if the indication is right. And sometimes we do what we call it a TLIF or PLIF, which is transforaminal or posterior lumbar interbody fusion. And this is basically putting a spacer instead of the disc. We take the whole disc out and put a metal spacer in there and augment that with the posterolateral fusion, which is the screws and rods. From the cervical spine point of view, we do anterior cervical discectomy and fusion, which is the most common procedure in cervical spine, as well as spine injections. Of course, by no means this is an exhaustive list. In the NHS practice, I operate on trauma and tumors and all the posterior cervical stuff, some of the thoracic stuff as well, but because of the setup of the private practice in the field, certain operations cannot be done there. And from there, we'll start talking about the risks and complications. But I would like to stop here, and before we delve more into the surgeries and the risks and how we reduce these, would like to check if there is any questions or anyone have any query about the recovery program and what we spoke about so far.
If you have any questions, I'm happy for you to type them into the chat function and read them out for you as well. So if we just give it a couple of minutes and then we'll move on.
Yeah, I'm happy for that. Or if, yeah, of course. So if anyone has a question and would like to put the speaker and ask directly, that's absolutely fine as well.
Okay, thank you. Okay, there's no questions. If you want to carry on, Mr. Abdelaal, that would be fine.
Okay. Yeah. So yeah, these are the common spine surgeries, and we'll talk a bit about the risks and complications. And this is mainly because complications do happen and risks do exist, and there is.
Yeah. There we go. Yeah. Perfect. All right, we're back on. All right, sorry about that, everyone. Thank you.
Okay. So general risks for operations, these include, of course, infection and bleeding and blood clots and devastating visual loss that very rarely happen, but it does exist. Something specific about the surgery for the spine is, of course, the dural tear and CSF leakage, which it does happen from time to time. There is also the risk of injuring of any of the structures that we work with, which is including, of course, the nerve injury, and that lead to weakness or pain. Development of a hematoma that can be expanding and can cause pressure on the nerves, and the coda equina syndrome. And we'll talk about these in a bit. And there is some approach-specific complications that happen mainly with things like the cervical spine surgery. Other complications like implant-related or the recurrence or adjacent segment disease, these are things that happen on the long run rather than immediately after the operation. So for the aim of this talk, we'll talk about these things that are highlighted now. So first, one of them is the dural tears and CSF leakage. So percentage of it happens in roughly about 5% of cases of spine surgery, particularly in the lumbar surgery. Risk factor, the biggest and by far the most important, is revision surgery. When patients have an operation on the lumbar spine, the same level and the same side before, there is usually a lot of scarring in there. That scar tissue, as it forms, it becomes adherent to the dura, which is the lining of the nerves. And by pulling on it or biting a little bit of scar tissue, the dura can very easily come out with it, and then you can see CSF everywhere. But other factors, including the age of the patient, so the older they are, the more likely for them to have a dural tear because the dura's usually become a bit thin. Surgeon experience, of course. Certain conditions like OPLL, which is the ossification of posterior longitudinal ligament. That's because it's associated with some scarring and adhesions as well. Diabetes, and prior steroid injections within the previous 2 to 3 months before the operation. And that's why if anyone is going for surgery, I would refrain from offering them injections in the previous 3 months. And the main worry that we worry about dural tears is because of the formation of this fistula, which is a connection from the spine or from the nerves all the way into the skin, and continuous leakage of fluid. And if it drains quite a bit, that increases the risk of infections, of course, because any blood can travel from the outer side of the body, the skin, all the way into the nerve tissues and subsequently the brain. But it's also because of the pressure effect that creates, because that drains all the fluid that is around the brain. And occasionally that can lead to devastating effects like subarachnoid hemorrhage, for example. The majority of them are asymptomatic, and as we know from the sports trial, which is one of the biggest randomized trials in the spine surgery, the dural tear, when they happen, the most likely outcome is it doesn't change in the outcome. It just increases the hospital stay because patients need to be lie flat and maybe observed for a bit longer than what they usually do. Patient get positional headaches, bulbable bulges on the back, increasing back pain, signs of increasing the intracranial pressure like vomiting or tinnitus. And of course, probably the first sign that we see is the CSF drainage from the wound, which is like watery drainage, serous fluid or serosanguinous fluid coming out of the wound. And if that happens, of course, it's a CSF until proven otherwise. And if we leave it, it can lead to progressive neurological deficit as well. So the primary goal for treating these is, if it happens in theater, is by obtaining a watertight closure, watertight sealing of all the tissues. So we use sutures, and there is also the some substitutes for the dura, like the fibrin glue and the collagen matrix, and these are synthetic material. But we can also use patient's own tissues like fat grafting or fascia grafting. And then we sometimes we put a drain and sometimes we don't. And this is maybe one of the only indications where a drain might be indicated. But again, I don't use a drain routinely if that happens. And this is one of the pathways that I find it very useful and helpful to know what to do after a dural tear. And this is probably one of the most frequent questions from the nurses and particularly the physiotherapy on the ward about mobilizing a patient that had a dural tear in theater the day before and what to do with them. And these instructions need to be really clear in the operative notes, but also can change according to how the patient is doing. So as we can see, if a patient should lie supine for the first like 24 hours or at least until the next day. If they are doing all right, then we can start sitting them up to about 30 or 40 degrees. And if they are okay for the following 8 hours, then maybe by the afternoon or early evening, they can start mobilizing. And if there is a drain, that can be removed once it stops draining. And sometimes before we remove the drain completely, we clamp it and see if when we clamp it, would the patient get any symptoms or anything like that. And if they are all right and start mobilizing, then they can go home. And most likely they go home on day 2 or day 3. But at any point, if they start showing signs or symptoms of continuous CSF leakage, then they will need surgery. And that's mainly to prevent something called meningoceal, which is like a soft collection of this CSF just under the skin, and that can cause problems and eventually, because initially it is a collection of fluid, but then nerve rootlets can easily migrate and herniate into that fluid, and that's when the problems start happening. And this is what's called the meningocele. And if that happens, then there is always the non-operative treatment. We give them a lumbar corset to apply pressure on it to stop it from expanding any further. We can watch and wait and see how that goes. And if the patient becomes asymptomatic and there is no back pain or any neurological deficit, it is very valid to continue monitoring them. But we need to monitor them, so we offer them close follow-up. We don't just discharge them until we make sure that they are all right. And it also is helpful to talk to colleagues. So if orthopedic surgeon will talk to our neurosurgical colleagues and vice versa. But also communicate all the plans well with everyone that is involved in patient care, including, of course, the patient themselves. But if it doesn't settle down or if the leakage continue, then we need to take them back to theatre for surgical repair. So something else is the compressive hematoma. So the hematoma is a collection of blood that happens routinely after surgery, and the body usually deals with that extra bit of blood that bleeds afterwards. But in some circumstances, this hematoma becomes bigger, and as it starts solidifying and becoming more solid, it starts causing compression or pressure effect on all the nerves. So after the initial improvement that they had for the first few days, they start getting the back pain getting worse again because of the pressure effect. But more importantly, the pressure on the nerves, so they can feel that their pain that they had the operation for is actually coming back. And in some extreme circumstances, they have the coda equina syndrome, which is pressure on the nerves that supply the bowel and bladder function. And then this becomes an urgent referral. So, of course, for any physiotherapy or GP, if they've been contacted by a patient because of increasing symptoms, if it has been increasing after an initial period of having been better, then that has to be on the differential list of problems, along with the dural tears and CSF leakage. If there is any change in patient neurology, the best next investigation is usually an MRI scan, and in that case, we order it with contrast, and that's important because after the first few days of the operation, there is usually a little bit of blood and some scar tissue starting to form. And if you get a normal MRI scan, everything looks the same. You don't know what is residual compression that was left from before the operation, from what is the new. But with the contrast, it easily or very nicely differentiates between these two things. So we can tell that this is fluid. Actually, this is a hematoma and the size of it, or this is a residual compression from before the operation, or indeed a recurrence, which it does happen as well. And I would always advise to get the MRI scan with contrast within the first 3 or 4 months of surgery. So anyone who had surgery within the past 3 or 4 months, his or her MRI scan would be with contrast because of that. If this hematoma is large or expanding, causing progressive neurological deficit and discomfort and pain, then usually the best way and most likely the most straightforward way is by evacuating the hematoma. So open the wound and wash it out, and people usually feel significantly better afterwards. Of course, it can set back the recovery a few steps, but they usually go back on track soon after. And of course, the coda equina syndrome, and that's probably one of the most scary things that any of us would see, and any of us meaning spinal surgeons, but also GPs and physiotherapists, and we get lots of referrals because of the query coda equina syndrome. So the coda equina syndrome is by definition compression of the coda equina part of the nerves. And these are the urinary nerves and bowel nerves, and the nerves that supply the saddle area or the perineum. And sometimes people come complaining of bilateral leg pain. The bilateral leg pain or radiculopathy that has been recently added, probably in the last 5 or 6 years, into this category of coda equina syndrome. Because when we looked into the long-term result of these, we found that about 20%, so 1 in 5 people presenting with bilateral leg pains would end up having a coda equina syndrome. And if there is any suspicion of coda equina, we advise for you guys to refer urgently for an urgent MRI scan. And if the diagnosis is confirmed on an MRI scan that matches patient symptoms, then they are usually offered an emergency surgery pretty much straight away. As we all know, the pressure on the nerves or the nerve roots, in general, the nerves that go down the leg, they can withstand pressure for a long time, and they do recover. But coda equina nerves are very, very sensitive. You press on them for 48 hours, and they might stop working forever. And that's why this is an emergency. Some specific complication that is related to the approach, and that's mostly related to the cervical surgery, anterior cervical surgery, of course, because of where it is and where we go. So we go from the front of the neck to reach the spine, which is more toward the back. So in that way, we encounter all the structures that is in front of the neck. So we go between very close to the carotid arteries and in between the windpipe and food pipes on one side, and all the major vessels that go from the heart all the way to the brain on the other side. And along that, we encounter some nerves as well. So of course, because of the close proximity to all the airway, any hematoma or a bit of bleeding there can affect the airway. And a small hematoma or developing hematoma there can cause severe airway compromise. That can be an emergency as well and needs a very emergency surgery. The risk of that happening is probably within the first 24 hours of the operation, and it's very unlikely to develop later on. So that's why we watch them for the first 24 hours or so. There is a nerve, the recurrent laryngeal nerve, that runs upwards in the neck, and it is very close to that approach, very close to the spine. So sometimes stretching of that nerve, people wake up with hoarseness of voice. In the vast majority of conditions, that recovers by itself within about 3 or 4 months, if it lasts for that. But the vast majority make a full recovery. Horner syndrome is an injury or a stretch to the sympathetic plexus, which is very close to the spine as well. Again, it's something rare, but it can happen. And usually patients will have a problem with their vision, and they will you will know it once you see it. So their eye pupils become very small, and they become the whole pupil seems as if it is bulging out, and it affects their sweating abilities as well and all of that. And again, in 99, probably 0.9% of cases, it recovers spontaneously. It's very unlikely that it can be a complete injury. Swallowing problems, of course, that happens because of the pressure on the food pipes as part of the approach, especially if it is 2 or 3 level surgery. So that pressure on the esophagus or the pharynx can make them wake up with painful swallowing, or they can't swallow food straight away. And again, that usually settles within a few days, and they can eat again. And it might take a few weeks until it settles down completely. Awareness of these complications is very important before the operation, and it is part of the consenting process and patient information that I was talking about earlier. And by them knowing that these things might happen, if any of it happen, they are not panicking. They are aware that these things do happen, and hence the response is usually okay. So at the end, we'd say, as we say, the journey of the patient starts well before surgery, and probably the bit that is before surgery and immediately after surgery is far more important than the surgery itself. Managing patient expectations is very important, and that's by giving them a good overview of what to expect during and after the operation and the recovery. A lot of people would come concerns, for example, because they will not be able to drive, or that would be their livelihood. And by just reassuring them about how many weeks or so they can start driving afterwards, that put their minds at rest. Patient information leaflets is very important, and I give that to patients routinely. Collaboration with colleagues, especially at the time of complications, that can be very helpful as well. The main aim of ERAS is to improve outcomes. It's not about the speed of recovery, but as a byproduct of it, as a bonus of it, usually the recovery is a speedy one as well, and the length of hospital stay is significantly reduced. And complications do happen, unfortunately, but fortunately they are not that common. So I don't think that we need to be too scared about complications that happen, especially with something like ERAS protocols and these things. If protocols and guidelines are in place, then we can easily manage them. And I think that's the end of the talk. So do we have any questions?
There's a question for you in the chat section. Do you give patients physiotherapy back exercises post-op or just functional movements?
Oh, exercises as well, yeah. Both. So functional movement, that's the minimum. But I give them exercises, especially stretching exercises. The things that we ask them to refrain from is anything that would increase their straining. So no deadlifts or anything like that. But exercises are very important because it's as we say, they hit the ground running, and that is mainly to help with their back pain. So if someone coming with a large disc and had discectomy, so it will warn them about the risk of recurrence, of course, to avoid things like deadlifts and weight exercise in the gym. But by rehabilitating them, asking them to do swimming, for example, once the wound is healed, that is extremely important and helpful.
Thank you. Are there any more questions? I'm happy for you to come off mute or type them into the chat function if you'd rather. We'll give it just a few minutes for any questions. Okay, just whilst we're waiting, just take this opportunity to thank you, Mr Abdelaal, for this evening's talk. Apologies everyone for the slight hiccups with the technology. Unfortunately, these things can't be helped. So thank you very much for bearing with us whilst we managed to get back online. So like I say, that's the last talk now for this year. And I will be in contact with any future talks. Another question for you in the chat function, Mr Abdelaal. Are you able to quantify the level of increased risk of dural tear in NRIC has been performed in prior 3 months? What is the believed mechanism of increased risk?
For an injection, following an injection. Is
so
that right?
dural tear, if NRIC has been performed. Yes,
I believe
yes,
it's
that's right.
a nerve root injection, I guess that is.
Oh, yes.
No, it's difficult to quantify it. This came from a study that looked at these and identified these risk factors, and one of them was that. And that's mainly because there is always an element of inflammation after any procedure that we do. And if you have heard of something called arachnoiditis, which is inflammation within the nerve rootlets and clumping of these nerve rootlets together, and that usually happens after injection. So by the same mechanism, is that degree of inflammation that the injection creates. Sometimes that, majority of time, that inflammation is useful because that is how we sort the pain, and the injection does its work. But as a result of that inflammation, there is some adhesions that develop between the nerve rootlets and the dura, and that can make it more prone for injections. But how percentage it is, I'm not aware of a certain figure, and I would be really reluctant to put a certain figure to it, because as we said, like in dural tears in general are rare. They are significantly higher in revision surgery, and that's the main thing, because this scar tissue is well established there, and it's not reversible, so it stays there. But apart from this, the risk is between 1 to 2%, so it's not that high. And I would think is with the injections, it's probably the same. Does that answer the question?
Just wait for a reply. Does an increased BMI increase the risk of tear as well?
No, increased BMI that increases the risk of surgery in general. All the risks are increased. In relation to the dural tear itself, it probably doesn't directly increase the risk of dural tear, but indirectly it does, because it's usually a difficult access. It's deeper surgery. Visualization might not be as optimal as in thinner or low BMI patients. So the whole operation becomes, and of course, it makes it bleed more. So the whole operation becomes more difficult in the higher the BMI is. But I don't think there is a direct link between high BMI and dural tears. But there's definitely an indirect link between dural tears and all other complications as well.
Thank you. Do you have an age? Oh, sorry. Do you have an age cutoff for spinal fusions?
No. So I think physiological age is far more important than chronological age, because particularly in a place like Coventry, in the NHS practice, where we see lots of people with trauma, for example, and tumors, you can easily get a patient who is 50-year-old but look like 80, and vice versa. We see patients who are 80 and look like 50. So the chronological age is not really that much relevant. It's more important the physiological age and how fit they are. I don't know if you know that, and that is in all aspects of surgery. But the Queen Mother, before she had a hip replacement when she was 100, so that just tells you how that is. Mm.
Okay, thank you. Right, I think that's all of the questions. I don't think there's anything else. Thank you very much, Mr. Abdelaal. Thank you for answering the questions for us.
No, thank you, Vicky, for organizing it, and thank you everyone for attending. And I apologize for my earphones.
Okay, no problem at all. All right, thank you very much, everyone. I have popped the link for the the link for the feedback in the chat function. If you wouldn't mind just completing that, that'd be brilliant. So thank you for joining us, and I hope you enjoy the rest of your evening.